To the Southeastern Synod workshop on trauma-informed care. As Pastor Michael mentioned, my name's Adam Renner. I'm a counselor in training and a graduate student at Georgia State University's Mental Health Counseling Department. Also a candidate for the Word and Service roster, so I'm very excited to be here with you today. So we have an awesome presentation for you all today that is being led by the Reverend Don Bennett. And we also have some other expert mental health clinicians who will be part of our panel. So I'm just going to ask if those folks would just introduce themselves really quickly. We do have a lot of information to get through. So Pastor Don, would you introduce yourself first?
Yes, good morning. My name is Dawn Bennett. I am the pastor at the table in Nashville, Tennessee.
Okay, Dr. Hooper?
I am a state licensed clinical pastoral therapist in practice in Brentwood. I also serve part-time as the Minister of Pastoral Care at First Lutheran in downtown Nashville.
Okay, and Miss Jeannie Ingram.
Good morning. I'm Jeannie Ingram in Nashville, Tennessee. I'm in private practice.
All right, thanks everybody. Now before we get going, I'm just going to give you a quick idea about our format for today. So as Pastor Michael mentioned, we're going to be recording this this presentation, at least the presentation portion of it, so that others can learn from it if they didn't get a chance to attend today. So we're going to open up with a presentation by Pastor Don, and there will be an exercise or two as we go through it. But this is intended to be an open discussion, so if you have any questions, you can feel free to post them in chat. And I do ask that since we will be recording, to save any sort of more deep questions until the very end. And if you have a question or comment that's sensitive in nature, you can feel free to message it to me privately, and I'll read it anonymously on your behalf. And since we are talking about a difficult topic today, if you are finding yourself activated at all or in need of some personal support, we do encourage you to message Jeannie Ingram privately in the chat. And then you two can go into a breakout room for a confidential consultation and some extra support. So with that, I will turn it over to Bishop Strickland, who is going to lead us in prayer.
Thanks for being with us, everyone. It's good to see your faces and to know that you're in this safe space. God be with you.
Also with you.
O God, and who calls us to be still, to be quiet, who knows our inmost thoughts, our anguish, our grief, our trauma, our joy. You knit us together, and most days put us back together. Guide and direct our hearts. Use us for service. Remind us of your never-ending care. This we pray in your name. Amen.
Amen. All right, so I'll be sharing the slides for the presentation, and Pastor Don, if you'll just tell me when to advance them, I'll be happy to do that. So I turn it over to you.
Thank you so much. We'll wait for there we go. Oops. There we are. Good morning. Thank you for joining us. A few housekeeping notes. A presentation like this requires a few disclaimers. This is only a bird's eye view into trauma-informed care. It sits at about 34 minutes, so hopefully it will bring you along in your practice, but also whet your appetite to do some further research on your own. I do want to leave considerable amount of time at the end for discussion. Also, this is an interactive presentation. By my count, we have 18 people on the call, and so a bit later, I'll be looking for volunteers to do a little bit of reading. Next slide, please. These are the objectives and the outlines of the presentation. This is going to provide a moderate introduction into the field of trauma-informed care, and in particular, trauma-informed pastoral care. We will look at assessments and some warning signs. We will look at how our trauma impacts our praxis. We will look at pastoral care by age, developing a trauma-informed pastoral care approach. And this section, actually, I'm going to gloss over instead of a deep dive. What I've provided is a resource document at the end, and Adam will dump that in to the comments, the chat box, when we get to that point. And then finally, some resources, some recommended reading, some websites, and some opportunities for further education, most of which is free. Next slide, please. These are the objectives. We're going to develop a deeper understanding of how trauma operates. We'll learn to assess trauma in ourselves and in those that we serve. Hopefully you'll gain some confidence to provide trauma-informed pastoral care, and finally add some resources to your toolbox. Next slide, please. We'll begin with our own understanding of trauma. And so this first exercise, I'm going to give about 60 seconds, and I ask that you write down your understanding and definition of trauma and answer the questions that you see on the screen there. What is trauma? What constitutes trauma? And how long does trauma last? And I will put 60 seconds on my clock, and feel free. About 30 more seconds. All right. However far you got is wonderful. Thank you for participating in that. Next slide, please. Trauma-informed care has its, excuse me, has its roots in the medical community. And as pastors and servants of God's people, we know that it is a very short hop from the healthcare environment to a pastoral care environment. For that reason, it is important to have a basic understanding of trauma-informed care from the healthcare field, and this short video will help us get there.
Okay. Pardon me just a moment. Need to make sure that I'm sharing my computer sound. Can everyone see and hear that real quick?
I can hear it, but
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma.
Sorry.
can't see it. We can.
Oh, you can't see it.
We can hear it.
Oh,
We can't
okay.
see it. So
Sorry
you
about
share
that.
Yeah,
Okay.
share the YouTube screen. Thank you.
Sorry about that, folks. Okay. How about now? Can you see?
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're gonna end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
But what we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
Next slide. Okay. So for our purposes this morning, I want to lift out 2 points from the video. Trauma-informed care takes physical, mental health, and the state of our soul into consideration. And the second is that as practitioners ourselves in the field of ministry, we want to help people return to a state of joy and to reconnect with their purpose for practicing their faith. So trauma, for the purpose of this presentation, is anything that causes an increased physiological stress response in your body. We acknowledge that some trauma in life is unavoidable, natural disasters, witnessing violence on TV, or car accidents, things of that nature, scary medical procedures. But trauma due to neglect or abuse of some kind is altogether different. And it causes toxic stress, which is a persistent drain, like a dripping faucet, if you can imagine that. This kind of trauma is prolonged, it's frequent, intermittent sometimes, or it's unbuffered, and the person has no ability to defend themselves. And this can result in the brain getting stuck in an adaptive survival mode, which might result in decreased ability to learn, behaviors that are less than socially acceptable. So you see there on the screen, we use terms to define the cause of this change in the brain as trauma, complex neurodevelopmental trauma, toxic stress, and adverse childhood events, which actually is going to be our jumping off point in this presentation, because as pastors and servants, much of what we deal with is trauma that's brought on from prior lived experiences. Next slide, please. Indicators of trauma are often invisible until they're not. And the results in, see, these are some of the warning signs: inconsolability, rage or outburst, violence that's deemed over the top or extra, mood swings and eating disorders, risky behaviors, depression, isolation, thoughts of suicide. These could all be signs that someone has been triggered into a trauma response. And remember that trauma-informed care asks the question, what happened, not what's wrong. It's a very different approach. Last week, if you were on the call last week, you may recall that Jeannie responded to someone who'd indicated that because of the pandemic, they're not acting like themselves, that their behavior is different than normal. And I thought Jeannie's response was spot on. She said, we are normal people having normal reactions to abnormal events. Likewise, a person who's activated into a trigger response is acting natural to them. They are either unaware or unable to redirect their response. And that's why it's important to be able to spot the warning signs. Next slide. Next slide. When someone is activated into a trauma response, it's often a conscious or an unconscious trigger response to a prior adverse experience. And many of these adverse experiences stem from childhood, and they're unknowingly carried into the future. Next slide, please. A trigger response is the result of toxic stressors that might be the response of ACEs, adverse childhood experiences. Now, the ACE study was published in 1998 from Kaiser Permanente and the CDC in conjunction. It's a groundbreaking article. It showed the startling link between traumatic events in childhood and the health and well-being of adults decades later. The questionnaire asks it asks about 10 kinds of adverse childhood experiences, as well as health risk factors such as smoking, alcohol, tobacco use, and exposure to sexually transmitted diseases. So this is another interactivity. The next set of slides that you're going to see, I invite you to unmute yourself. The next set of slides will ask 10 volunteers to read aloud and just jump in. It's quite all right if 2 or more people choose. We're going to read 10 statements. They're actually the 10 questions on the questionnaire. And there's a reason why we're reading and hearing these aloud, and it will become evident as we move through the questionnaire. Just remember that these indicators took place before a person's 18th birthday. Next slide, please. And a volunteer for question 1.
Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt?
Question 2.
Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured?
Question 3.
Did an adult or person at least 5 years older than you ever touch or fondle you or have you touch their body in a sexual way or attempt or actually have oral, anal, or vaginal intercourse with you?
Question 4.
Did you often or very often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other?
Question 5.
Do you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Or your parents were too drunk or high to take care of you or take you to the doctor if you needed it?
Question 6.
Were your parents ever separated or divorced?
Question 7.
Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Or sometimes, often or very often, kicked, bitten, hit with a fist, or hit with something hard, or ever repeatedly hit over at least a few minutes or threatened with a gun or knife?
Question 8.
Did you live with anyone who was a problem drinker or alcoholic, or who used street drugs?
9.
Was a household member depressed or mentally ill, or did a household member attempt suicide?
And question 10.
Did a household member go to prison?
Thank you for your participation. Next slide, please. When we ask how the ACEs study impacts our pastoral care, we acknowledge the widespread impact of trauma on those the church is ministering to, excuse me, and alongside of. Next slide, please. To that end, in trauma-informed pastoral care, we also take into consideration the 4 R's mentioned in the earlier video from the medical community. What you're seeing now has been adapted from the Substance Abuse and Mental Health Services Administration, SAMHSA, their trauma-informed approach. And this model shows us what it could look like to belong to a trauma-informed church. We practice the 4 R's. A trauma-informed pastoral care model practices the first, that we realize the widespread impact of trauma on those that we serve with and alongside. We recognize the signs and the symptoms of trauma as well as affect living with a traumatized family member has on everyone in the home. We respond to the needs of the congregation and the surrounding community by integrating knowledge of trauma into the planning of our ministries, our policies, and the stewardship of the church's resource. And finally, we aim to resist re-traumatization of victims that can occur when recognition of trauma is not combined with compassion and destigmatization of mental health treatment. Now here we also have to pause and remember that we are mandated reporters. Trauma-informed care must also take into account reporting of abuse procedures. The most important thing to remember is that the ACE score is meant to be a guideline. Those 10 questions that we read, for each yes, that indicates 1 tick mark, and at the end you add those up, and that is called your ACE score. In my prison work, I remind folks that the ACE score is a useful tool toward personal healing. A score doesn't define who you are, only God defines who you are. A person's ACE score helps to answer what happened to them, which is the question that we ask. It's also worth mentioning there are other forms of trauma that were not part of the ACEs studies, such as bullying, racism, vicarious trauma, which is witnessed violence of extended relatives, pets, things of that nature. These traumas only work actually to heighten a person's trauma activation. But our ability as pastors and servants to build the capacity to provide responsive support is critical to ensure protection for us and for those that we care for. Next slide, please. We would be remiss if we did not stop to consider ourselves and our own lived experiences, because we acknowledge that we pastor from a very personal context. To that end, it's important for us to do our own personal work and stay aware of our own triggers. We also need to remain conscious as to when to make a referral if the care needed is beyond what we have the training or the capacity to provide. Next slide, please. What you're seeing now is the SAMHSA.gov shortened version of the ACEs questionnaire. And I'm actually going to give you a few minutes to complete this on your own. Just a few housekeeping things. I want to remind you that your ACEs score does not define you. It only identifies what happened to you. And also, this is a good time to remind you that we have a confidential pastoral care provider. If you need, in the chat box, just connect with Jeannie. And I'll give you probably 45 seconds or so. There you go. Give you another 30 seconds. Okay, next slide, please. In addition to practicing, excuse me, the 4 R's, trauma-informed church also considers these core principles. We aim to provide pastoral care which delivers an increased measure of safety. Throughout the parish, we need to set an environment for staff and for families where they feel physically and psychologically safe. Pastoral care is delivered with transparency and with the goal of building and maintaining trust. Through peer support, we seek to establish support groups for individuals with shared experiences and create ways for them to be a life-giving part of the church. We provide care through collaboration. We aim, actually, that's the goal, is to level power differences between the pastor and members so that we can work together to support shared decision making. That's very important for a person who has experienced trauma, that they as much as possible have autonomy in their own decision making. And finally, empowerment. Well, not finally, but empowerment. The pastor and the members' strengths are recognized, built on, and validated. That's all part of that autonomy. This includes a belief in resilience and the ability that people actually can heal from trauma. And finally, in this slow, tender, vulnerable work, through trauma-informed approach, our biases and our stereotypes, such as race and ethnicity, sexual orientation, age, even geography, those are all taken into consideration along with historical trauma. We, as much as possible, we recognize and we address these biases. Next slide, please. As we move on and we talk about resiliency and helping our members thrive, we look at ways to cope with trauma that in turn help return joy and a sense of balance to one's faith life. These three principles work to support resilience, reduce sources of stress. Regular, reliable help would be far more impactful than reducing household stress than occasional gifts. Some suggestions are, when possible, food pantries, clothing closets, school supplies, bus ministry, bus vouchers if you have them, teachings about forgiveness, conflict resolution, anger management, things like that. The second principle is to strengthen the core life skills, teaching parenting skills to young adults and teens, or partnering with a local pregnancy center who often offers these classes for free. You might be able to host. Teaching financial literacy or job skills training, again, hosting programs like Scouts or 12-step recovery or re-entry programs. They can go a very long way in helping reshape our faith communities. And this also may be a good opportunity to build volunteers and give them an opportunity to become involved. And finally, support responsive relationships. Now, this may look different with generations getting to know one another if you have the benefit of intergenerational activity, mentorship programs, discipleship, or single mother ministries for cars and handiwork repairs. Oftentimes, single moms don't have this skill set, and it would be very, very welcome. Support groups for grief, divorce, adoption, foster families. All of these things happen oftentimes in and around our congregation. So the idea is to find out what the needs are and then mine for resources within your congregation and your local community. Next slide, please. Finally, we'll move through the age groups on the left and pair them with the trauma-informed practices on the right. And this is where I made mention about that document that I sent to Adam. In respect of time, I'm not going to go through the whole thing in depth because I want to leave a good amount of time for opportunity for questions. But I have, if Adam will drop that document in there. The document is rather long, which is why, for the sake of time, I'm not going. But when we paired the ages on the left, each age group goes down that list of security, accountability, felt safety, and it gives you resources and ideas of how to pair trauma-informed care into each age group that your church serves. Because we need to remember that we are all children of God, and we're children of all ages. Trauma is universal, but the way that we provide pastoral care is very contextual. Next slide, please. I have the printout, so I have to go all the way back here. Okay. What you're looking at is resources on books here. The next couple slides will be all resources. The Body Keeps the Score, Brain, Mind, and the Body and Healing of Trauma by Bessel van der Kolk. I would say that this belongs on every person's bookshelf. There's a few there that you can see I've put an asterisk by. That one, Teens Who Hurt, Clinical Interventions to Break the Cycle of Adolescent Violence by Ken Hardy. That's another great one. Some of you may have on your bookshelf Pastoral Care Emergencies by David Schweitzer. There's a few chapters in there that are particularly useful, responding to suicidal persons and their families, because remember, trauma impacts that person, but everybody also who's in connection to that person. And then also, it's very important to know when to make a referral. So chapter 11 in that same book by Schweitzer will be helpful to kind of parse some of that out. And next slide. These are some websites that are probably most common. You'll see samhsa.gov in the middle. That's a super useful website. There's a couple also, mypronouns.org is particularly useful with LGBTQ+ persons because being misgendered, if a person is activated into trauma and they identify as transgender, misgendering them, even by accident, works to very much heighten that trigger response. So learning about pronouns and the use of pronouns and how it can work within trauma activation is important. So my pronouns is good. And then that crisis text line that you see, 741-741, that is, that's a great website. A lot of folks now, because of being online, they don't feel comfortable reaching out by phone or reaching out on camera. And so there is a sense of autonomy and confidentiality when you can text for help. And this text line is, it's staffed by persons who are trained, particularly in trauma. It's very comparable to calling the suicide hotline or mental health crisis line. These folks are trained in trauma. So there is a different number for the UK and Ireland, which I have. If you think that would be helpful in making a referral, please feel free to connect with me and I'll pass that along. And the last screen, please. This is for further training. The resources that I put up on the screen are all free. They offer a variety of opportunities for future learning. A lot of them are webinars that you can take at your own pace. They're all accessible online there. Crisisprevention.com is a really great website for trauma-informed care. And then youth.gov. The government really has done a really good job in collaborating with local partnerships throughout the country to really amp up the services that they provide online. And then also that last trauma-informed care training, that is where the video is from. So you'll be able to access that again. Of course, the video will be on the Synod website along with the presentation. But I know that was quick. It was about a half an hour. And you know, those of us who work in trauma have been doing it for years, so it's really hard to learn it all in a half an hour. But hopefully that will get you started, just to, if at the very minimum, help you delineate pastoral care that is trauma-informed, as opposed to pastoral care that heavily relies on scripture-based only, right? There's a lot of different. And to be able to come into pastoral care and providing the help that the folks in your congregation need, it's very helpful to have a background in a basic understanding of how trauma operates, so that you'll be able to at least spot some warning signs. And then, of course, you know, knowing when to make a referral. I would imagine that Dr. Hooper and Jeannie will be quick to respond. It's critical to know when to make a referral. So that's all I have for you. I'm going to ask Adam now to just open up to Dr. Hooper and Jeannie and let them field some questions along with myself, if I can be of any help.
Thank you so much, Pastor Bennett. Wonderful presentation. And we do have about 15 or 20 minutes for discussion and questions.